So my name is Stephen Furmanek. I am a senior biostatistician here at the Norton Infectious Diseases Institute. And thank you, Dr. Wild, for the overview of observational studies. And now we're going to talk about some interventional studies. So we are still very firmly in the study protocol, but our study design really impacts a lot of different aspects of the sort of idea to publication pipeline. And so, as I said, we are very much in the study protocol. Our study design, one thing I want to mention is that it is very important, as we've talked about collaboration here. Study design is not something that you should come up with on your own. And as a statistician, I can very confidently say that if someone were to say, I'm thinking of doing a study, what are your thoughts? I would love to discuss them with you. So continuing on, an interventional study is when we have an investigator that is applying a treatment or intervention that's then going to directly impact the outcome. So as Ashley alluded to, we may do interventions and observational studies. Let's say that we draw blood from patients because we're doing an antibody surveillance study. And so we're trying to look at antibodies, let's say for COVID. Well, the act of drawing blood from that patient isn't going to affect the presence of antibodies in that patient. So in that regard, that is an intervention, but it is not an interventional study. So in an interventional study, we are always looking at an intervention that's going to impact an outcome. And so in our study design and our rationale, we want to make sure that there's biological plausibility and all of that. So in our interventional study, we are going to have two groups, the experimental group and a control group. And so the experimental group is going to be the group that's receiving our intervention, and the control group is usually going to be receiving our standard of care or a placebo. Now, there are many different types of interventional study designs, and they're listed here, and we're going to go through them. The gold standard, of course, is a randomized clinical trial or randomized controlled trial, as it is also commonly referred to. But we have many alternative clinical trial designs that kind of play with some of the parameters that are involved. And so first we're going to discuss randomized clinical trials. So our study subjects, as you remember, are taken from a larger population. And in a randomized clinical trial, you're going to select a sample of subjects that has very well-defined inclusion and exclusion criteria. So these inclusion and exclusion criteria are then going to demonstrate that there is minimizing our confounding or bias. And then after consenting, we are going to randomize patients, again, for the purpose of minimizing confounding and bias. And then we will blind patients, and oftentimes the investigator themselves, or possibly even the statistician, so that way there will be less bias or chance of bias on the part of performing the study. And then patients in the experimental group will receive the intervention. We'll follow them over time, and then we will observe their outcomes. And in the control group, patients will typically receive a placebo. We'll follow them over time, and then observe for those same outcomes. So then a randomized clinical trial is the best study to demonstrate causality. And so the best way to prevent the influence of confounding variables is through randomization. There are multiple different types of randomization, and typically most randomized clinical trials are industry-sponsored studies. And so if you are an investigator looking at doing a randomized clinical trial, I strongly suggest that you get with a statistician to talk about randomization and how you plan on doing that. The best way to prevent bias is through blinding, as I've mentioned earlier. And so the randomized clinical trial is the best study design to show whether or not your intervention is really causing the outcome. Of course, we will get to whether or not causation is being demonstrated in later presentations. And it's the optimal study design for testing your intervention. Of course, since there are very strict inclusion and exclusion criteria, that may make generalizability not very, it may limit your generalizability. Most clinical trials will exclude pregnant people, they'll exclude immunocompromised patients, they'll exclude patients who are on various drugs. They may only look at patients in certain settings or with specific diseases, so that really diminishes your external generalizability, because then your study population starts looking less and less like the target population that you have. And then there's also other barriers to performing these, largely cost, time, feasibility, all of those. So an example that we have is a Repexarin study, and Repexarin is an IL-8 inhibitor. And I bring up this example because this is actually a study that the Norton Infectious Diseases Institute will be performing later this fall. So in this study, our patient population that we're drawing from is patients hospitalized with CAP. And so we're going to get community-acquired pneumonia patients in the hospital. We're going to consent them, randomize. They'll be blinded to what treatment they're getting. And then our outcomes of interest are going to be their rates of recovery, the number of ventilator-free days that they have, and then also mortality. So moving along to alternative clinical trial designs in our pragmatic trials, these trials generally ease the inclusion and exclusion criteria so that they're more generalizable. And so they have a more representative sample because there's less strict criteria. So then we will still consent patients and they'll still be randomized, but usually the randomization is by cluster or through like hospital systems. And so the control group may be an intervention or standard of care. And then the experimental group is again our experiment. And so then the outcomes are going to be relevant to our patients that we have. Now, the pragmatic clinical trial is designed to test the effectiveness of an intervention in a real world clinical setting that's more routine care. And the goal is to maximize generalizability. So then randomization, as I said, is often cluster based. So it might be different wards or different hospitals or different hospital systems. And then oftentimes they will trade off doing pre-post interventions. And so these are, the randomization is handled through that manner. So we're not randomizing necessarily individual patients, but the units that they're in. And then the data collection is designed to be easily accessible through, say, the medical record and through routine care. And an important point is that randomized clinical trials and pragmatic clinical trials exist on a continuum. So there may be, you may have a stronger inclusion criteria than others. So you can mix elements of these two studies together. An example of a pragmatic clinical trial is in Utah, there's a hospital system, and I have the clinical trials number up there. And we'll also make sure that there's in the slides, you all have the citations as well. But they have a hospital system that had 6 different clusters where they did a stepped approach where hospitals were given this intervention. And the intervention was what's called an ePNA, which is it was part of their EMR that was installed, where it was a system for making recommendations and suggesting, say, microbiology or treatment options for patients that were showing up with pneumonia symptoms. So this was a study that occurred over the course of several years, and then they eventually had every hospital system operating with this ePNA system. In quasi-experimental studies, the main difference here is that randomization does not occur. And so you will typically select subjects that appear similar or exist in a similar context. And then patients aren't randomly assigned. The control will either be an intervention or standard of care again. And then we'll still look at outcomes. So why would you ever consider a quasi-experimental study? Well, sometimes it may not be ethical to randomize or feasible, or maybe there's something that makes it difficult to randomize. So Maybe you have a criteria that's non-random that you're using to assign patients into being in the treatment or control group. So an example of this study is back in the fall of 2020, there was a nursing home system that was looking at vitamin D boli, excuse me, in patients. And so every patient was getting a vitamin D boli or bolus every 3 months. And so the experimental group would be then, based on the timing of symptoms, a patient that received a vitamin D bolus within 1 week of COVID symptoms appearing. Every other patient that had COVID symptoms would be in the control group. So this way they could test the effect of vitamin D to see whether or not it was an effective treatment. So this came out around the time where vitamin D was of big interest in COVID treatment at that time. Pre-post intervention studies. These usually involve one group of patients. We aren't planning on publishing this. That may be changing, but in that you will assess before the intervention happens, you will follow a group of patients to look for outcomes. You'll administer the intervention, and then after that intervention, you'll also assess that same group of patients. So in this way, each patient is operating as their own control. And the downside of these studies is that the outcome, if their intervention is at a specific point in time, then the outcome could be affected by things that happened around the same time as that intervention. So let's say that we have a learning course and it's a knowledge test, but all of your patients, there was a really bad accident and traffic was terrible that day. Maybe that changed their outlook and everyone was in a really bad mood and tested poorly. In that case, your intervention may be confounded by other external factors that happened at the same time. And for an example of the pre-post intervention, that EPNA in the hospital systems, they actually used a pre-post study where they had a lead-in time before introducing the new EMR changes and then afterwards. So that was actually a combination of 2 different study designs. In adaptive study designs, you're going to have more than one experimental arm. So in this group, we have potentially as many experimental treatments as you can think of. And what will happen is you will, over time, change the allocation into these different experimental arms based on the results that you find. And so the adaption here refers to this rebalancing of how patients are being enrolled into these groups. So patients are still being consented and randomized, but maybe you've closed arms to enrollment because you found that that treatment isn't effective. And so the example that we have for this is the recovery trial. And this is a pretty well-known COVID trial. They started out with about 6 or 7 different study arms and a control arm. So some of which they had low-dose corticosteroids, they had lepanavir, ritonavir, they looked at azithromycin, hydroxychloroquine. They looked at, if there was ever in the news you heard of a treatment for COVID, they have an experimental arm assessing that treatment. And so the original study arms are closed, but now, so Paxlovid is one of the current study arms, and then the control arm is, of course, still going on. Now, the interesting thing about this example is that the research paper that they did, the manuscript was published in the New England Journal of Medicine for their low-dose corticosteroids, and that has impacted COVID treatment. Because before this, there was not really any evidence besides expert opinion. So we have a higher weight of evidence now with this trial for low-dose corticosteroids in patients. And then the last study design we'll talk about today are factorial designs. And so a factorial design lets you assess 2 treatments, but you could test them independently and in combination. So let's say that you think that there's going to be a confounding or a effect modification of a drug on another drug, you could use the factorial design then to test for that. So a lot of times studies early in COVID were looking at the combination of azithromycin and hydroxychloroquine. So back in the recovery trial, one of the study arms was actually this AB crossover group where they had both azithromycin, hydroxychloroquine. And so this way you can test combinations of drugs as well. Now, the important thing to know about interventional studies is that you can combine many features of them and kind of tweak your interventional study to fit your research question. And once again, I just want to make the appeal that when you are planning an interventional study, you should involve a statistician. That way they can get on board, because you're planning the study for an interventional study then guides your data collection form, it guides your data analysis and everything else. And this is also true of observational studies, but in an observational study, since there's not an intervention that's being administered, that's not, I don't want to say it's not as important, because it is, but it's especially important in an interventional study. So, and with this, I think we are breaking for lunch and then coffee. Sorry, not lunch. It's too early.